Good afternoon, sir.
Good afternoon.
The macular-threatening tractional complications of proliferative diabetic retinopathy, when we treat with pars plana vitrectomy, it not only stabilizes the proliferative status of the diabetic retinopathy, but also improves the oxygenation of the eye and reduces the cytokine load in the vitreous cavity. And in this milieu, if it is coexisting with a diabetic macular edema, the macular edema also tends to resolve. But there could be surprises. Surprises even in those eyes which did not have any diabetic macular edema at the time of surgery, as in this particular case, where we do not see the evidence of diabetic macular edema, but when followed up for 6 months, there is an appearance of the macular edema. So how to manage it? We do not know the natural history of this kind of diabetic macular edema, which develop in vitrectomized eyes, which were treated for proliferative diabetic retinopathy. And the treatment for this DME in particular is not standardized. So to fill this knowledge gap, we tried to audit our own cases, which were operated between 2014 to 2019 at our hospital. The study was approved by the IRB, and the study, which was retrospective, followed the tenets of the Declaration of Helsinki. So all those cases which had documented evidence of diabetic macular edema following vitrectomy were included in the study. And also those eyes which had a persistent diabetic macular edema for at least 6 months following vitrectomy were included. So what we excluded were the eyes which had gross fibrovascular proliferation lifting the macula, that is macular traction. The eyes which did not have OCT documentations either pre-op or at particular points post-operatively. The eyes which were treated with silicone oil or had multiple VR interventions, eyes which developed macular holes, and those eyes which did not have a follow-up of at least 1 year after the baseline. So we curated 56 eyes out of 1,039 records, and if we see, it's a very small fraction of the eyes which developed diabetic macular edema following vitrectomy. And with the inclusion and exclusion criteria, we settled with just 36 patients. So these eyes, when operated, were followed up every 3 months, and at the end of 6 months, if these eyes were detected with vision loss or diabetic macular edema more than 250 microns, they were offered with treatment, informing the patients that we do not have evidence on the efficacy of the treatment. So few of the patients would agree. As we see on the left hand side, the patient agreed for intravitreal injection, and when followed up at 9 months, although there was a reduction in height of the CST, the vision remained the same. So what about the other side? The other patient did not agree for a treatment, and when we followed up at 9 months, the macular edema had worsened. So we grouped these two kind of treatments, the one which received treatment in group A and which did not receive any treatment in group B. And all these groups were followed up for at least 1 year. The study followed all the standard statistical analysis for comparing the continuous and categorical variables. The strength of association between the two variables were represented by odds ratio and 95% confidence interval. The p-value was set at 0.05. So if we look at the intra-group effect of the treatment, when treated with anti-VEGF injections, the CST improved. The same improvement also was seen in those eyes which were not treated. But even after treatment, the visual acuity improvement was not significant in group A. So this could be because of the small number of cases that we had. But surprisingly, the group B, which had no treatment, had shown an improvement in vision. So these patients were followed up quite handsomely, like nearly 2.5 years or 3 years. If you look at the intergroup comparison, there were variables like the eyes which had systemic involvement, they were significantly more in group A. The preoperative PRP was done more often in the observed group. The baseline central subfield thickness was more in group A, and the diffuse nature of the edema was more so in the group. When we compared the post-operative parameters, most of them were comparable, both the central subfield thickness and the vision. So the key defining elements of this study was that this kind of complication is seen in a very small fraction of eyes when treated with partial vitrectomy. And although there is a continual morphological improvement, at the end of the 1 year or 2 years, there may be a persistent cystoid macular edema or sensory macular detachment if they are just followed up. So to conclude, vitrectomized eyes are already, since they are already in a reduced state of cytokine load, they may be just observed than being treated immediately. Since the follow-up for this study was 1 year, we do not recommend treatment for at least 1 year.
What do you think the mechanism of cystoid macular edema in the post-vitrectomized eyes?
Thank you for the great question, sir. When we looked at the patients who were presenting to us after the analysis of this study, we would find that either the renal parameters would be deranged or the blood sugar would be deranged. But since it was a retrospective study, we didn't have any clue what had led to the reappearance of macular edema.
Were these cases were combined surgeries or only vitrectomy was done?
They were only vitrectomized eyes, and none of them received silicone oil. It was just a fluid exchange after the surgery.
Why do you think that on OCT, the diabetic macular edema remained after removing the traction?
If we look at the edema following epithelial membrane removal, the mean time of resolution of that edema is 8 months. So in this study, or as a protocol in our hospital, we do not offer treatment for at least 6 months.
No, that's fine. But why do you think it remained?
Because the tissue remodeling takes time.
I feel that there are just two components, maybe whether you agree or not. Even when you see, obviously, how do you see that there is macular traction? On OCT.
Yeah.
But there is one more thing to it. In case the edema is focal, and the difference is much more as compared to LC, then we can say that it is only because of the traction. But if it is diffuse macular edema with some rise in focal areas, then you can say that both the mechanisms are acting. So I thought that in case it is not resolving early, it may be that there was a presence of diabetic macular edema and traction also added to that.
Yes.
You relieved the traction, but the diabetic retinopathy mechanism kept acting, and therefore that diabetic macular edema remained. Second thing is, once there is disorganization of the elements, no matter what you do, there would not be any improvement in vision.
Usually,
We thought that you would, at LVPI, they are quite good in formulating the parameters of the study.
The groups, I believe, I don't know how you made a comparison. pre-operative findings of patients and, in both the group, how could you, keep them similar?
It
You know,
is
that
not
was-
similar.
And
There are
the
a lot
second-
of parameters which were
That is point one. Second, which I thought maybe you are not the only person operating, so it's a operator-dependent outcome as well.
Of course, yes.
And then, as you mentioned, as in your slides, that the pre-operative laser has an effect. So even the laser during the surgery may have the same effect. So basically, it may depend upon the surgeon. You may find out the surgeon as well.
And the duration of time when it was noted and the patient was subjected to surgery is an important parameter.
yes.
But anyway, it's a good study. We are happy.
We will actually
Thank you.
observe for a while.
Thank you.